Yeah, given that Chris and I didn't speak before this evening, I think we've done rather well in coordinating our messages, really. And I guess, yes, this is... I'm getting baffled by the technology. It's not a good start, really, is it? I guess this is really a story about time and pressure. This is a story about money and recession and Northern Rock. This is a story about the 5-year forward view, and it is a story about large-scale population change. And I think all of that's the absolute fundamentals of what we're going to talk about. My career in the NHS started in 1996, so you have to picture me a bright-eyed, bushy-tailed management trainee, excited by the last year of a Conservative administration where spending on healthcare services were, I think, at a record low. But very quickly moving into New Labour, and over the 10 or 12-year period from 1997 onwards, investment in the NHS tripled in cash terms, doubled in real terms, and the world was kind of opening up before us, before plateauing out. So money is quite an important part of the conversation that we need to have today, really, about bringing technology together with people and making better outcomes. So these were the 2010 figures, and this is the best picture I can find of approximately the 2015 figures. Nobody's produced a pictogram quite as easy to understand as this. The Guardian did provide a whole set of excellent bubble pictures, but that gives you some sense of where healthcare falls within the overall expenditure in the UK. So approximately £1 in every 5.5 or something is spent on, that's about right, isn't it? Yeah, it's spent on healthcare, and it is the biggest single, and although welfare is up there, it is the biggest single departmental spend, and it sends everybody kind of bonkers within government. The levels of control and politicisation of healthcare are very significant. People often tell me that the problem with the NHS is it's too politically interfered with. I think I'd respond and say the problem with the NHS is it's not politically interfered with enough. It's too important to be left alone. It's really important for the city, the region, the country and the world, and politicians should be interested in every moment of it. So heaven forfend that we should have a system like the States where health is outside of the federal purview and it sits with states, which is just a disaster. So we should celebrate the political interest in the NHS rather than anything else. Healthcare expenditure is rising. You all know this, I guess. There's various bits of research that will tell you that. This is some more detailed data, really, about the way different groups within our population use health, and particularly the number of bed days used by populations as they get older. So this is the way people consume healthcare resources as they age, right? So these are the things that you'd expect, or hopefully you'd expect, and they begin to help us model how we consume and manage our resources. There's quite a debate about the ageing population, and frankly it depends where you live as to what the ageing population means for a health economy. Shire counties versus urban centres, whether the ageing population simply stretches out the curve or makes it a different shape. These are many debates that Chris and colleagues have. There is no straight answer, and the data is emerging. Certainly the work I've done with a number of commercial colleagues, particularly PwC's section, which does the math on this stuff, tells me that people aren't getting more expensive, they're just taking longer to consume the expenditure. There are more people, though, so the quantum is changing, and that's really important. The 5-year forward view, has anybody read the 5-year forward view? Hands up. Okay, that's quite a good start. It's a pretty key document if you want to get into kind of healthcare. It does represent the government's view, largely, of where we're going, certainly over the next 2 years. I don't know about the next 5. That's probably pushing it a bit. But certainly it's a trajectory taking us towards the election. There's lots about hospitals in there, quite a lot about GPs, a bit about new models of care, a bit about public health, not much about mental health, not much about local authorities, certainly not much about the public, and very little about the voluntary sector. So there are some kind of yawning gaps in it, but it does focus on the significant resource base of the health service. I was asked to talk about primary care this evening, and I guess what I would say, particularly of Coventry, but of most primary care economies, is it is diverse and variable. I would put it in those terms. There's some outstanding parts of primary care, and there's some areas that need to improve. Primary care nationally has experienced significant workforce pressures. So in Coventry and Rugby, we are running vacancy rates of 15%, so 15% of our GP-based workforce. We have vacant posts. Only just over half of the GP trainee posts for the region this year have been filled. And people don't want to become GPs at the moment. I think that's right, isn't it? You know, or not enough people want to become GPs. Some people want to become GPs, but not enough. They are a highly innovative group of clinicians. They are small business people. They are healthcare professionals. They are doctors. They are public servants. They are entrepreneurs. They are all sorts of things. And they are highly, highly innovative. This is both good and demanding. And there is significant frustration amongst the primary care community about lack of progress around digital delivery. So they are champing at the bit. They are interested in better care for patients, and they are interested in effective systems. And those are at the top of their list of needs for primary care, I would suggest. They recognise, I think, absolutely the relevance and interest and effectiveness of digital healthcare delivery routes for younger populations particularly, although they do recognise its applicability across the whole demographic. They are concerned about witless NHS and government policies being imposed centrally. They are also clear that not everyone wants to participate. There are a number of primary care practitioners, many of whom you'll have come across, who don't want anything to do with it. They recognise, and I think we should recognise, there are a number of patients who don't want to do this stuff. They want face-to-face, old-fashioned contacts. Now, what people want and what we can afford and what there is and what we get is a complex equation, but it is one we need to be aware of. There's a significant amount of innovation already in place. There are increasing tele and digital healthcare practices being explored and piloted. The nice thing about working with GPs is they do their own thing. It's also the frustrating thing about GPs is that they do their own thing. But quite often I'll come back from some meeting and say, wow, do you know we can do this? And 3 of the GPs in the room have said, yeah, we've been doing that for 10 years. You just think, oh, okay, right. Similarly, when it turns out that we think we can do something, they say, no, we tried that 10 years ago, it doesn't work. So it kind of works both ways. They are highly innovative. They write their own code. They create systems, they run reports, they run telecare, they run near-patient testing, they run all sorts of stuff that the Department of Health says isn't possible, and all sorts of stuff that the Department of Health says we're going to do, they say doesn't work. So it is essential to work in partnership with our primary care colleagues, and if we don't do that, it won't fly. There is lots of individual innovation and lots of pockets of good practice that is going on, many of which I think colleagues in the room are in contact with, but there's all sorts of kind of unexploited nuggets of delight out there. They are interested in being pilots. They are interested in new things. They are interested in being first. They're quite a competitive group, in a positive sort of way. Professionally competitive with one another, also financially competitive, which is something to watch. They are using a whole range of technology around near-patient testing. They're quite interested in primary care-based clinical workup for secondary services. That's quite important. So they recognise the pressures within the secondary care environment, within the hospital environment. They're interested in doing the front end of that workup. Now, secondary care may be less interested in them doing the front end of that workup, and there's a whole world of pain in that conversation. However, this is at the same time as hospitals would assert that they are far too busy, unable to manage their current activity, and need to change things and bring things out into the community. Whether or not they really mean it is a whole other conversation. There are pilots for large-scale population interventions that are being planned both locally and nationally. I guess this is the risk. This is one of my favourite cartoons at the moment. This is the Lone Wolf Support Group. A very sad wolf by itself. The risk of not providing a supportive and cooperative and collaborative environment for GPs and primary care is because it's such a diverse community that they'll just go off and do their own thing. And if it works, that's great. If it doesn't, that's disastrous. So we need to think really hard about that and work to provide an environment for that. In terms of innovation yet to come, I look after Coventry and Rugby. We won a Prime Minister's Challenge Fund grant. There's another 36 of them going on elsewhere in the country, so I'd like to say we're special and different, but it turns out we're not that special or different. And certainly within Coventry, we're moving, we've got 3 programmes going on around shared primary care records, consultation methods and booking systems, which are technology-based, which several colleagues know about in the room. None of these are particularly groundbreaking, except they've not been done on scale, generally. So the opportunities are considerable for our whole population. We've got a population of about 490,000, not quite as large as Chris's, but a decent size. So there's a good 500,000 people to kind of focus on. If we can make shared primary care records work on that scale, then I think there's some real learning there that can be shared elsewhere, and some real improvements in care that can be provided. There is significantly more opportunity in working with secondary care. Delving into large hospitals is hard work. Their clinical systems are both old, generally, and difficult to penetrate. The rewards, if you're able to achieve that, are significant in terms of improved care, in terms of integrated provision and records. There is a great deal of patient-driven demand, especially around lifestyle risk management work, I think. Increasingly, my iPhone measures the number of flights of stairs that I've climbed, and people's watches and devices do various things. And I was hearing earlier today that people's cars can do all sorts of clever things. And there's a lot of tech around, which people are kind of playing at. The question is how can we turn public interest in playing into real outcomes in health improvement? How can we take the people who are enjoying playing with the tech and turn it into whole populations who are willing to use the technology, not just play? And how strong is the motivation to change behaviours rather than just fiddle with clever apps? And those are the questions that we have yet to explore on scale. However, the early signs, the early science, the early learning seems to tell us that there's real opportunity there. My final thoughts. I guess my view is we have to succeed with digital technology channels and deliver effective interventions in primary care. It won't work otherwise. The technology and the techniques, especially the information sharing, which neither of us have really talked about, and there's a whole, I'd say it's a whole session in itself. It's a whole conference in itself. Not to mention several PhDs, one imagines. Information sharing is complicated and upsets people and needs resolving and isn't resolved. So we need to get through that. The technology and the techniques are new, so they don't all work, they're not all consistent, and they're uncomfortable. They're uncomfortable for people, they're uncomfortable for systems, they're uncomfortable for organisations, and they're uncomfortable for commercial partners as well. So that needs working through, we have to let go of traditional models of care and delivery and embrace new ones. I couldn't resist We Have a World to Win, given this was the WIN conference. I don't know if I'd get away with Mark's in a drafted council speech for elected members, but, depends on your council, I guess. But there is a need to lose inhibitions and experiment. There is a need to let go a bit and try new stuff. There is a need for some recognition that some of this might not work first time and that it will need revising, and we've got to have a go. Collaboration will be the delivery method for primary care, and I would suggest for the rest of the health economy, public health, secondary care, mental health, social care, locally driven, local innovations, working with local partners and not centrally directed.